Henoch Schonlein Purpura, better known as HSP, by Amanda Grindstaff. Introduction to disease. HSP is the most common form of systemic vasculitis in children. HSP has now been actually referred to as IgA vasculitis. IgA, or immunoglobulin A, is deposited within the affected organs of the child. The cause of the disease is unknown. It is suspected that agents such as infections, vaccinations, or insect bites may be the cause of HSP. HSP occurs in 10 to 20 per 100,000 children. Children of Asian descent have a higher incidence rate. It is more common in males aged 4 to 6 years, and it's more common in fall and winter. Rates are generally low for morbidity and mortality unless the patient has renal involvement. Renal involvement can affect 40 to 60% of pediatric patients within 4 to 6 weeks of their illness. Severity of renal involvement determines morbidity and mortality rates. Pathophysiology of HSP. As mentioned earlier, HSP is the most common form of systemic vasculitis found in children. It is an immune complex mediated disease with IgA deposition. It can have multi-symptom involvement. It's a palpable purpura rash found on the child without thrombocytopenia of coagulopathy association. IgA complexes are deposited in the skin, gut, and glomeruli. It triggers the inflammatory response, causing necrosis of the small blood vessels. It is often preceded by an upper respiratory infection or a streptococcal infection. There's a possibility that HSP is preceded by other viral illnesses such as parvovirus, adenovirus, hepatitis A, mycoplasma, and Bartonella. Signs and symptoms. HSP generally presents with a red or purple appearing rash. It is known as a purpura rash. The rash is caused by inflammation of the blood vessels, and the rash is generally non-blanchable. The rash is more common in gravity-dependent areas such as the legs and the buttocks. Other symptoms of HSP can include arthralgia or arthritis, abdominal pain, which occurs in 80% of patients with HSP, GI bleeding, and renal involvement. Males can have scrotal swelling that can cause them severe pain with HSP. Diagnostic evaluation of HSP may include a urinalysis to check for hematuria or proteinuria, stool occult blood. 30% of patients with HSP have blood present in their stool, a CBC for possible leukocytosis. PT/PTT is usually within normal limits. ESR can be normal or elevated. 70% of cases of HSP are preceded by strep, therefore you may need a strep screen. An abdominal ultrasound to rule out intussusception. A testicular ultrasound for males with testicular pain. This can also rule out a testicular torsion. Skin biopsies are rarely done on children, and renal biopsies may be done if the patient has progressed to renal involvement. Treatment of HSP. There is no specific treatment for HSP. The main goal is to relieve symptoms. First line, you could recommend over-the-counter medications such as NSAIDs or Tylenol for arthralgia or arthritis pain and swelling. NSAIDs, of course, are to be avoided if the patient is having GI bleeding. Opioids could be prescribed for severe pain, and it is recommended that the patient get plenty of rest and drink plenty of fluids. Second-line treatment would only be used if the patient has renal involvement. This would include high-dose corticosteroids that help to reduce proteinuria. Psychosocial implications of HSP. The appearance of the rash alone could have an impact on the patient, especially if this is in an adolescent patient. Some of these patients have very severe pain, which can decrease their activity. Some of them have organ involvement. Decreased activity and organ involvement that requires hospitalizations and a lot of different treatments could lead the patient to have depression. This disease could have an impact on the family because these parents have a fear of the unknown. They don't really know what to do for their child. And then when they find out what is involved with HSP and what it could lead up to, such as renal involvement, they get even more concerned. Nurse practitioner's role. It is the nurse practitioner's responsibility to obtain a history of the illness and any symptoms that may have led up to the illness. A physical exam needs to be performed and close attention paid to the skin, joints, abdomen, patient's blood pressure, and scrotum. The nurse practitioner can order labs and/or diagnostics based on the signs and symptoms. Patients with severe pain may be prescribed medications. The nurse practitioner can make referrals to specialists if they are needed, and it is their responsibility to determine if hospitalization is needed. Reasons for hospitalization may include dehydration, severe abdominal pain, GI bleeding, a change in mental status, severe arthralgia or arthritis pain, and joint involvement, renal insufficiency, hypertension, and/or nephrotic syndrome. The nurse practitioner needs to educate the patient and the parents of the illness. They need to educate them on what to expect and what to look for further complications. There are several websites that you can refer parents and patients to for information on HSP. The American College of Rheumatology, Johns Hopkins Vasculitis Center, and the Kids Health websites are all great websites. There are several others. The National Kidney Foundation actually has a support group for parents and patients who have children that have renal involvement due to HSP. AS is a 6-year-old male. He presents to the clinic today with a rash that has gotten worse per his mother. His mother states the rash is on his lower extremities and his buttocks. He has been having abdominal pain and back pain. What questions and what observations would help you to give a defining diagnosis of HSP for AS? What labs and/or diagnostic studies, if any, would you order for AS? If AS is discharged home, what kind of education would you give to his parents? Thank you. This concludes my presentation on HSP.